Hi, I'm David Harrison. Welcome to the first Perspectives on Health podcast. Each episode, we'll be talking with healthcare stakeholders about the trends and issues impacting healthcare today. Before we get started, I'd like to thank Pentax Medical for their generous support of this podcast. I really hope you enjoy this first episode with Dr. Anand Sahai. Dr. Sahai had some really interesting perspectives to share on practicing endoscopy and endoscopic ultrasound during the COVID-19 pandemic. Thank you for watching, and I look forward to bringing you more perspectives on health. So today we have Dr. Anand Sahai with us. Anand Sahai is a professor of medicine and chief of the GI division at the University of Montreal Hospital Center, or is commonly known as CHUM. He is a globally recognized thought leader in the world of endoscopic ultrasound and has received numerous awards from the ASGE and the American College of Gastroenterology. He works at one of the biggest centers for endoscopic ultrasounds, performing more than 2,600 procedures annually with an internationally recognized EUS training program. Dr. Sahai has trained more than 500 physicians globally across 5 continents, and he has published more than 200 papers and book chapters. He is a graduate of McGill University and completed his medical degree at Université de Montréal. Dr. Sahai completed his fellowships at Hôpital Saint-Luc and McGill University. Welcome, Dr. Sahai.
Hi, thanks for having me.
Well, it's almost hard to start any conversation with anybody these days without COVID-19 coming up and the impact that it's had on our world. How have you seen it impact how you're practicing at CHUM?
Well, we obviously in the hospital went into sort of lockdown mode and reduced all of our non-essential activities, certainly at the beginning. I was actually not working for the first 2 or 3 weeks. So I was basically just sort of sitting at home watching the news all the time. We brought all the kids back. I had one of my daughters is in the University of the States. We brought her back. And we have a cottage up north, so we were just basically all sort of huddled in the cottage. As I say, I think it was actually kind of a unique time for us to kind of get together as a family, because that doesn't happen, and really be spending all the time together instead of all doing different stuff, and having to kind of communicate a little more. So that was nice. Then I did start working a bit, and I'm to be honest, to me, we're very fortunate. We have a place to go. In medicine, you kind of have a job, so I still have some income and stuff. So to me, kind of working at about 50%, going to work with no traffic, just having a very quiet time in the hospital was actually very, very nice. It was an unexpectedly pleasant experience, but I think everybody's getting a little bit tired of it now.
Yeah, and obviously, you live and work in Montreal, and it's one of those great world-class cities. How have you seen that impacted as well? I know you enjoy going out to the restaurants and the shop, and particularly in the summer, it's a wonderful place to be. How are things been impacted there?
Well, I mean, I really find that the Quebecois population really listened very well. The place was shut down. I mean, when I would go to work, as I said, there was zero traffic. There was nobody anywhere. People really took it seriously. So it was really very, very, very quiet. And people, at the beginning, I think also everybody was very scared. And so when you would go, it's weird. You kind of at the very beginning, you sort of weren't used to the social distancing, like staying away from people and not touching stuff. And then pretty quickly you could see people got into it. And when you went to do the groceries now, it was sort of a scary experience. You're like, I really want to be careful. I don't touch anything. We were bringing the groceries home, washing all the groceries and stuff. And so pretty much everything was shut down 100% except for majorly essential services. That's it. Doing nothing else. Nobody really wanted to do any takeout even. So just get the groceries, eat at home, and do nothing else.
Montreal was one of the harder hit cities, though, right, for COVID-19 cases?
Well, the thing about Quebec, and I'm not sure what it was like in other provinces, but what happened primarily was that the fire caught in the old folks' homes,
Yeah.
and it was just it was a mistake. People just didn't realize that they were understaffed, that they had people, because they're understaffed, who were working in personnel who were working in several different old folks' homes. So
Okay.
once they got in, they would infect the whole place, and then they change, you go work somewhere else. And if honestly, if you remove all the deaths and the disease from the old folks home, it's about 85% of the deaths in Quebec were all in old folks homes. So if you
Wow.
take those out of the numbers, it was actually like there was almost no pandemic here. Really, there's a couple hotspots in Montreal, but it
Yep.
was really, the numbers looked so bad, unfortunately, because of what happened in the old folks homes.
Yeah, and I think Ontario and the Greater Toronto area had a similar situation where, a large majority of the cases did come from long-term care. Yeah.
Yeah, yeah, and I think
So
it's a
now
lesson we're
you're
going to have to learn.
back to working. What has changed? How have things changed at the EUS unit?
So our whole endoscopy unit is definitely running at the lower pace. We're
Okay.
only doing what we call P1 and P2 priority cases now. The hospital, has been trying to keep space in case they got overloaded. And there were some questions about the availability of PPE. So we've stopped teaching. We're not accepting any more residents into the procedures. We want to make them as short as possible, use as less PPE as possible. We're only doing P1s and P2s. So for regular endoscopy, that means that they're basically running at about 30 to 40% of their regular volume. So basically doing only the inpatients and then outpatients who are urgent or semi-urgent. EUS, if I could say, is, fortunately for us, is almost all P1 and P2s because it's all cancer screening and stuff like that. So we've been running, while they were running at, 10, 20% initially, we were about 50%. And now that they're up to 30, 40, we're running about 80%. So we're almost back to full volume in a unit that's basically very, very quiet and actually quite nice to work in now.
Well, and you would have had cases where there was higher risk of infection from patients in the past anyways, where you'd had procedures in place to manage that?
Well, the funny thing is the hospital, certainly the endoscopy department, is a very cold zone. So they don't let anybody in there who has anything close to symptoms. And unless if you're, they divide them into cold, warm, and hot. If you're classified as warm or hot based on your questionnaire or where you're coming from, we just don't do the procedure unless it's a life and death situation. Okay. So that means that actually we're quite protected in endoscopy. And I think you actually, in a sense, I would tell people, you probably have more exposure to virus doing your groceries than you do being in endoscopy.
Okay. And for all the elective procedures that have been accumulating during the shutdown, what would the game plan be to catch up on those, or is that possible?
I mean, that's the thing. I mean, it's, they're saying we're going to have to catch up, but I mean, we were already had a waiting list, and now we've been working at 30% of our regular volume for about 3 months. And the thing is, I don't see us certainly going back to more than 100% anyway after this is all over. And then the question is, when is this going to be all over? I mean, the hospitals are going to be very careful about just letting all kinds of people come in. There have been some outbreaks in a couple of hospitals in Quebec. As I say, I think the viral load in Quebec is quite low now, if you exclude the long-term care facilities. So I think it is still quite safe, but they're being very, very cautious about reopening. And then there's always the question about the PPE and stuff like that that's making them really take their time before opening up full time. So honestly, I don't know what we're going to do with this overload of patients. The Specialist Association is talking about looking at even private clinics as a way to catch up on the OR list. I mean, in endoscopy, at least we kept functioning to a certain extent, but the ORs were almost down to zero. And that's, I mean, those are, patients with proven cancers and stuff like that, just waiting. I mean, just waiting for surgery.
Right, right. One of the other areas that obviously is going to undergo a great deal of changes around training and education. How is CHUM adjusting for that? And also yourself, you're obviously run a very busy training program for EUS and attract people from all around the world and had a long waiting list, I think over a year and a half. So, how do you see things playing out there?
So for the CHUM itself, for the regular GI program, they basically stopped allowing the fellows to do endoscopy. As I say, they wanted to reduce the endoscopy time as much as possible. There was a big question about PPE at the beginning, so they didn't want to waste any PPE. And there's a issue of safety for the residents. It was a little contradictory though, because they were sending the residents into the emergency room and the COVID wards, but they wouldn't let them do endoscopy. It was a little strange. And then they started saying, okay, well, it was everybody. They just sort of get impatient, and then it's like people's criteria start changing. So the residents obviously wanted the scope, and they started saying, well, I think we'll start letting them come in, and I had to sort of ask them, if this was Ebola instead of COVID, would you be starting to say, well, let's let the residents come back in? Either it's safe or it's unsafe for them.
Right.
I think what's happening though is that people are realizing that COVID for younger people, if they get ill, is not quite so bad. So I think they're sort of at the beginning, we were very scared. There were people saying, even young people were getting on respirators and stuff like that. But I think now we're realizing that the young people are fairly safe. So slowly we're starting to feel like it's okay for the residents to come back in endoscopy. I think the PPE situation is pretty good because the whole hospital load of patients is going down. So we're slowly bringing it back in. As far as our program, the major issue is that now they can't even get in the country. The Canadian border is closed. And then even if the border opens, we're not sure if they're going to ask for some type of confinement for how long, or some quarantine, or what the criteria will be to let people come into the hospital. They have to have a negative test or 2 negative tests. I don't know. It's still up in the air. We basically, since the border's closed, we haven't even asked many more questions for now.
Okay. So, there's been some talk about maybe things easing down through the summer, and then, this fear of a second wave, maybe as the fall cooler weather starts coming again. And I think they've seen some of these secondary outbreaks in other countries. Is there some preparation going on for that you're aware of?
As far as the hospital, no, other than they're probably going to be very careful about filling up the hospital. But, I think people, because of this, are going to keep being careful, which may even help with the regular flu. I think people are going to stop shaking hands. They're going to, so I think in the end, it may actually be, if people are as careful as certainly Quebec, I think, have they been, it may actually turn out to be a bit of a benefit for the whole flu season in general.
Okay. Yeah, that's right. So yourself, you've been obviously doing this for a very long time, and you've had this interesting and unscheduled break now. How do you keep energized? How do you keep a passion for doing these therapeutic endoscopy and ultrasound?
So because of the course we do, this is the 20th year. I think for the last 20 years, this is the first time in 20 years that I haven't been scoping with somebody beside me, like just scoping alone,
Wow.
And to be honest, I kind of like it. So because the procedures are way shorter, you get in, you just look around, you do it, and you get out, so it's much more efficient. But I must say, I'm also realizing that the fellows keep me honest, because if you're alone, sometimes you go too fast. And when you're with the fellows, you kind of have to go over and over, and you sort of go, oh, yeah, it's a good thing we look at that again, So it's kind of interesting. So as I said, I'm enjoying this, and I guess I've decided I'm going to take it as the whole COVID thing, the whole situation, as a once in a lifetime, hopefully, situation where and sort of enjoy the good parts while you can, but get ready to go back to the way it was.
Right, right. Now, prior to COVID-19, you were also traveling a fair bit, going to Asia, going to India, going to Europe, and speaking. Tell me about how your experience here in Canada and running one of the top programs in North America can help you, advance the U.S. and these other markets.
Well, I think that I'm curious to see how much people want to go back to all this traveling after this is over. To be honest, when I'm thinking about it now, it's like, wait a sec. If we can do all this by Zoom or whatever, do we really need to be there? Could we just set up our lab with a good camera system and do these live broadcasts, and everybody can stay home and safe, and So I'm really curious to see what's going to happen with all these live courses.
Yeah, it's a great point, because I think COVID-19 has forced that behavior, and we're seeing a proliferation of some really, really good events done online. I think Endoscopy on Air was last week and was very well followed, and some great cases. And I think you're right. I think this has forced people to reconsider how they're doing things, and there's also some virtual conferences now starting to be coordinated. So it's definitely, I'm not so sure things will go back to normal.
Although one thing I am seeing, especially in the American TV, because now all the news shows are on, everybody's at home, is that the internet in the States is really bad. Like they really have trouble communicating. Like they keep going off. I think our internet quality in Canada certainly is better than it is in the States. I can tell you, my daughter who's in New York, her phone service is with, I don't know what company, but it's horrible. The quality of the service they have there is really not as good as here. And I think that's one thing that if we are going to continue, we're going to have to. I mean, this is not so bad, but I think it will probably improve the standard of care in what's acceptable in transmission quality and all that will probably be raised, so that we're going to do these meetings more and more. But you can't have a lousy internet connection, and you're going to have to, if you want to be involved, you're going to have a serious way to communicate with people.
Yeah, hopefully the Canadian telecom companies don't hear your comments there, because we still want them to raise the bar a bit more.
No, maybe with 5G and everything, it'll become just seamless and everything. But it amazes me watching these major news networks, and literally, I think 10 to 20% of the time, their interviews, they cut out. The guy loses their connection, and I'm like, wait a sec, come on, this is CNN. Like, you guys can't maintain a proper internet connection with somebody. It's really amazing.
Now, for the uninitiated, could you describe a little about why EUS is such an important tool for physicians?
So I think in medicine, our goal has always been to be, especially with therapeutics, cancer treatment, stuff like that, to be as minimally invasive as possible. So certainly in GI, what we're trying to do is always do things that help avoid surgery. An endoscopic ultrasound is a procedure that combines high resolution imaging with the ability to access tissue or provide therapy without cutting the skin. Going through, it's basically natural orifice surgery or diagnosis and stuff like that. And it's a very unique thing that I don't think any procedure will ever be able to do. Like, you can get the best CT scanner in the world, but even if it identifies a 1 or 2 millimeter lesion, it won't be able to biopsy it under CT guidance without going through the skin. Yeah. So ultrasound allows you to avoid, and when you go through the skin, there's always, it's painful. There's a risk of spreading tumor, stuff like that. So endoscopic ultrasound, even though our ultrasound technology, the resolution may not be as great as some other imaging technology, the combination of that resolution with the ability to get up close to stuff and then touch stuff, biopsy it or treat it, is unparalleled. And that's why EUS, I think, has become so important.
Yeah, because originally it really started out as a diagnostic tool, or staging
It was
of
for
cancer
staging
tool.
cancers. Yeah.
Yeah, and now, as you said, with the ability to biopsy, it certainly has much greater utility. So what are some of the other advances you're excited about with
Well, I
respect
mean,
to therapy?
the scopes to begin with are just getting better, smaller, better, better optics. The ultrasound qualities, I think it's been somewhat static, but what's been good is that they've been able to keep that level with smaller probes, which is good.
Hmm.
Um, what I think is exciting now is that for EUS, we're finally getting devices that were designed specifically for EUS. So at the beginning, when we were doing therapy, we were just using stuff that was made for ERCP and that weren't necessarily easy to see by ultrasound. And what we're finding now is that they're designing things that really can be seen very well by ultrasound, that you don't need fluoroscopy, and that really require, they're specifically designed for EUS. So even somebody who does ERCP, if they don't know how to do EUS, they can't just do what we're doing anymore. And as I say, it's kind of funny because all those ERCP guys who were laughing at us for the last 20 years, saying that we were a procedure looking for an indication, all of a sudden they want us to teach them EUS. And they're finding that the ERCP volume is going down, and we're taking over more and more of their work. My feeling is that ERCP will be reserved for stone disease,
Okay.
but for everything that's cancer related, EUS will probably be the primary modality.
And are we seeing kind of maybe an in-between period here where we're doing these back-to-back procedures, and is that wise, or will that trend continue to evolve?
The reason we do back-to-back now is because patients who come in with obstructive jaundice, for example, will get which looks like a pancreatic cancer, probably there's a mass on CT or something. In our center, they get an EUS first for a diagnosis, and then they go to ERCP for biliary drainage. Yeah. But we're actually currently doing a randomized trial of EUS guided drainage for distal malignant obstruction versus ERCP. It's actually a Canadian trial being run by Yenny Chen at McGill. And I think that we're going to show that if EUS can see the bile duct properly, it's better to just, while they're there for their biopsy, to do the biliary drainage at the same time. It saves the procedure. The EUS guided biliary drainage literally takes about 20 seconds. Once you're in there, you put in the device, click, you've got the drainage done, and you're out. And there's no wire exchange, there's no fluoroscopy. The long-term occlusion rates of the stents appear to be very good. There's no risk of tumor ingrowth because we're not going through the tumor like ERCP. And I think it's really going to, as I say, it's going to eliminate the need for ERCP for distal obstruction. For hilar obstruction, the EUS approach is more of a transgastric hepatogastrostomy approach. And the device for that's a little bit more complicated procedure. And they're working on making a lumen opposing metal stent for that, which is the easy sort of click device. But they're still not there. But if that comes out, then there's really all you RCPs can have left is stone disease.
Okay. Now, I've also seen you speak at a few conferences, and you've been fairly outspoken about taking samples and biopsies. And what are some of the biggest misconceptions that you see out there that still happen quite a lot that you think don't add a lot of clinical value?
About tissue acquisition?
Yes.
I mean, misconceptions from other
clinicians.
I guess they may think that it's that EUS is sort of complicated to do, or that we don't get great tissue. But honestly, an EUS guided biopsy of a pancreatic mass, it's somebody who knows how to do EUS, literally takes about 3 minutes. Mm-hmm. Our needles now are no longer doing just cytology. We have amazing core needles that have a diagnostic accuracy of close to 99% for both benign and malignant disease. So it's important not just to diagnose cancer, but if there's no cancer, to provide a diagnosis of a benign pathology, so you don't keep going back to repeat the biopsies. So I think people, what I found at the beginning of EUS, certainly, for example, in the mediastinum, which was sort of a very hidden place where you could only access by surgery. When we started doing mediastinal node biopsies, the pulmonologists and the thoracic surgeons just couldn't believe we were getting this tissue from a compartment that was so inaccessible before. We were doing it in a minute. It was, in sick patients with almost no sedation. And I think some people who aren't familiar with the US don't understand how easy it is to get access to so many different areas with such high accuracy.
Wow. And when you look at where EUS is going, and where would you like to see the technology evolved? From an R&D perspective, what would you like to see the systems be able to do?
So I think the smaller the better, as long as the scopes don't get too floppy. You need a certain amount of rigidity in the scopes to get things done in some difficult situations. Personally, I think the scopes now, even the therapeutic scopes, are almost the same size as a gastroscope. So I don't think there's much more work to be done there. As I say, I don't think the ultrasound image needs to get that much better. Better would be great. I guess more penetration would be good. My goal is not really to improve the technology that much. I think that being said, there's some people who are very keen on a lot of almost trying to get the system to do the work for the doctor. Like you just put it in and it lights up all these colors and tell you what the diagnosis is. I don't think that's going to happen ever. Like just never. Yeah. I mean, you can't just let a machine. You have to be able to position the scope properly. You need to be trained. You can't just stick it down and expect the system. Even CT scanners. You still need somebody to read the scan.
Right.
There's some interesting, this technology elastography, where the sort of optical biopsy, which I think is being used too much in malignancy. I think there is some hope for it in non-malignancy, so that might be something to be worked on with some better studies, because I think the quality of the studies is lacking because they've been focusing primarily on cancer.
Right.
My ultimate goal, I think, for EUS, if you say the technology is pretty much where it needs to be, is to get it in the hands of more people. So I think that we need to get EUS taught at the beginning of GI training, not at the end. And it should basically replace the gastroscope. So if it's the same size as the gastroscope, but it allows you to do endoscopy and ultrasound and tissue acquisition and maybe therapy, I think it should be the workhorse scope for everybody who's going to get an upper endoscopy. May as well get an EUS instead of a gastroscopy.
So for the payers out there, whether it's in a public system or a private system, what's the argument for doing that?
So EUS scopes are certainly more expensive than regular scopes. Initially, they broke very easily because they were mechanical scanners. But now with the fixed array scanners, if your people know how to take care of them, they're very durable. For sure, if you do break the ultrasound portion, it's expensive. But the cost per procedure obviously goes down depending on how many procedures you do. So if you do one procedure a year with a $100,000 scope, that's a very expensive procedure. But if you do 3,000, the cost per procedure goes way down. And then this scope, and the information you get will, allow you to avoid doing a lot of CT scans, repeat biopsies. It'll upstage a lot of patients with tumors so they won't get inappropriate surgery. I think it'll help outcomes by more. I think the more precise the staging is, presumably the better outcomes you'll get, because you'll be able to provide the most appropriate therapy, and you won't be over treating people who have, unfortunately, more advanced disease than you think it is. So I think in the end, it's an ambulatory procedure. So you keep people out of the hospital. But then, payers can say, well, if you keep people out of our beds and you keep cycling them quickly, there'll just be more beds to bring in people for surgery. So in the end, you'll end up doing more operations and it'll cost more. But if the goal is to really do the most efficient procedure that provides the best outcome for the dollar, I think there's definitely an argument for something like EUS.
Yeah, great point. Well, I think that's a great spot to wrap things up. Some fantastic insights from you. Really appreciate you doing this during this very uncertain time, and I hope you continue to enjoy the time with your family as long as it lasts, and stay safe.
Thanks very much. You too. Stay safe, and all the best to you and your family as well.
All right. Thank you very much. Bye now.
Take care.